thanks to all of you for all the great presentations, and really I hope that we can have more of those opportunities for healthcare providers to learn from your guys' insights. Dr. Bell, I want to start with you. So you briefly shared some of the frustrations that you have with the current model of medical cannabis. And what you shared with me last week was that some of those are impeding you sending patients to medical cannabis. Can you speak to some of those?
Well, prescribing medical cannabis is very different from prescribing virtually any other drug that I prescribe in an everyday practice. So first of all, the entire model of the model of the authorization document can be described as nothing short of bizarre. It's sort of a prescription to allow patients to go to a site where they can purchase medications that they don't need an authorization for. They can go and purchase the medications any way they want. Okay, so that's first of all bizarre, that this document does not offer any opportunity for the physician to specify a specific combination of THC CBD. It does not offer any direction for use or dosage. What kind of a prescription has no dosage on it? Okay, so that's number one. I mean, that's a huge issue, and it was nice to see that the legislation review has at least addressed it, and let's see if they act on it. When you go to the next step, though, once the patient I've given a patient an authorization. Typically, my patients that I've been authorizing for are cannabis naive. They're frequently elderly, and now they have to go to this website, okay? And they get to this website, and the first thing they see on the website is, okay, I'll use the term that was used earlier today in the discussion, Big Joe's Wacko Blunts, okay? And they've got I've told them that they need a specific dose of THC, a specific dose of CBD, and they're going to go to this site and they're going to see basically the same thing that they see in a pot shop. So I think that's a gigantic barrier to use for the patients. I mean, then there's all the other issues. Aside from that, just being computer literate enough to go to a website and order. Now, you can turn to the physician who can say, okay, well, I'll order it for you, but there aren't a lot of physicians who have the time or inclination or motivation to do any such thing. So, I mean, that's a gigantic barrier. Now, then there's the whole issue of, well, we're not just prescribing a single drug in a single dose, it's a combination of drugs, requires titration, and for somebody who's been prescribing cannabis for a long time, they get quite used to it and functional at it, but a newbie who is not familiar with prescribing cannabis is not going to learn this well, is not going to do it well, and is going to punt. And there's so much stigma around the whole thing that is a motivator also not to prescribe cannabis, because you might get known as a cannabis or a pot doc. So does that scratch the surface of the issues around authorization?
Yeah, just a little bit, and I think we do need to find a better way to have those medical documents submitted, and also perhaps review what we're doing in the medical portals and what type of access patients have to products.
Well, let me just jump in for a sec there. So Alan gave you the front end of it. Then the patient gets the product, and it's a bottle with a syringe, without a single direction. No matter how much time you spend with them in the office, they're calling you back the next day and saying, what do I do with this? And so if you want to fix something from the access to the patient when you're sending out, you should send some directions if you have an authorization that came in. And so maybe that's where the pharmacies come back into the game. Maybe it's where portals come into the game until the pharmacies are in the game. But there's a huge gap with how much time you spend with a patient, and they will not remember a thing. Maybe in the pediatric world it's a little less because parents are writing everything down and they know exactly what they're doing, but it's a huge issue.
Yeah, and we see this, our pharmacists do spend a lot of time going back in and teaching patients how to use the product and trying to remind them what those treatment plans were. But one of the issues there is actually from the Health Canada side that doesn't allow you to provide a pamphlet on dosing and titration on how to use that product. So all patients see is that it's a 1 ml syringe attached to an oil, and it isn't enough information. And unfortunately, on the industry side, we're stuck on not being able to provide that without having Health Canada come to us. So thank you for bringing that point up.
Karolina, can I just very briefly appeal to the industry in the room that I need a website that I can send patients to that specifies two products. One is THC, the other is CBD. It is not branded forms, it is oral formulations of these drugs that I can specify a dose and tell that patient what to choose on that dose. So they can get exactly what I have prescribed, and even with a titration schedule that I may provide them with, that they can go on to get it. And I mean, it sounds, I'm obviously very naive to think how simple that is, but it sure is what I need.
We'll keep that in mind going forward, and I think it is important to address that point. And Dr. Hans Clark, with your real-world evidence study, you've talked a little bit about the portal, the back-end portal that patients do go through to get products. You as physicians do suggest specific products, and do you find that helps those patients guide through that process, or is there still some limitations that we're missing throughout that?
So that's a loaded question. So I know we're about to relaunch this, but I just had one of my fellows authorize myself some cannabis because I wanted to see what the back end of the patient looks like. And I'm spending time in front of them on the physician portal. Doesn't look the same. So I'm giving them directions in terms of how to go and access this. And now I try to do it myself. They're not called oils. They're called, something else. They're in different spaces. So what I'm doing in my office doesn't even match what I tell them to do when they get in front of their computer. So if you're going to educate us to use our portal, we better know what they're doing as well, because we can't actually get them to this spot that Alan wants them to get to choose the oil that we've already authorized on this end. So I think there's a lot still to talk about in terms of how we can fix that process.
Yeah, I do agree with you. And what we see, for example, with WSIB is that patients can actually not purchase themselves through the online portal. They actually place a call to our pharmacist to process that order. And in that case, the pharmacists are actively working to make sure they're using the products that were selected. But again, that's a lot of time and efforts, and we're fortunate to have pharmacists to be able to assist with that. And I do know, flipping to the pediatric population, that is the case. We do get a lot of phone calls from these caregivers to help place the orders. I do want to switch a little bit of the topic because, Dr. Lewis, we have Epidiolex coming. And of course, Epidiolex is an approved pharmaceutical for Lennox-Gastaut and Dravet and TSC. What are your thoughts on this approval, and how will it change your scope of care going forward?
Yeah, so I think it's really important. So Epidiolex is now currently available through patient support programs. So it's actually like a real situation that I'm working with my patients. I think it's wonderful. So many of these patients, the barrier has been cost, and this is where I mentioned where Avicanna has been really supportive throughout the time, and why I've been appreciative of it, because consistently Karolina Avicanna has listened to me to say we got to reduce costs here, and I think you guys have done as best as you possibly can. But this opens up access to a lot of people. There's still so many of my patients who can't afford it regardless. And imagine again the needs of a lot of these families with how complex some of these kids are, and the adults as well. And so there's already a ton of costs for these. So I think it opens up a really important avenue for people with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex who are 2 years and up. Okay? But when I look at that, Lennox-Gastaut is, yes, the almost 10% of drug-resistant epilepsy is due to Lennox-Gastaut syndrome. So that's relatively a lot of people. But what about the rest of the 90%? Well, some of that might be Dravet syndrome, but Dravet syndrome has a prevalence of anywhere from like 1 in 15 to 40,000. So it's not that common. Tuberous sclerosis complex, again, 1 in 25,000. So yes, we've solved for a very small piece of the drug-resistant epilepsy population, but you have not. We still have to get access to all the others. So that's still an issue. And then again, Epidiolex is a CBD isolate. So we're just talking about CBD. I didn't show all of the data we had from our real world evidence, but it looks like, and this what translates into practice, some epilepsies are responsive to CBD alone, and some epilepsies are responsive to CBD and THC, and there's probably many others that are responsive to different varying degrees. But it looks like the THC is also necessary. So we still have that need that's going to need to be filled. So Epidiolex coming to the market is amazing. I think it's fantastic. It's going to be really good. It's going to shift practice. Oh, the other last point I'll just say is it's going to dramatically open the door for people, physicians, nurse practitioners, who might have been skeptical or worried or concerned, given all the issues Dr. Bell has raised here in terms of accessing and getting started and doing this stuff. It just makes it really easy. So that process is really easy because it's like prescribing a drug at this point. So I think it really will open up physicians themselves to be more comfortable prescribing cannabis.
And one thing we talked about in the past is physician comfort with prescribing medical cannabis, in that you still have patients that come to you, are looking for medical cannabis, that their physicians necessarily were not willing to open that door. And one of those challenges that you've talked about is that openness to get outside RCTs and start to consider what that endocannabinoid system does, which you gave a fantastic presentation on that. But can you touch a little bit more on that?
Yeah, so I mean, especially in the world of neurology, neurologists, maybe above all doctors, are such sticklers for evidence, right? It's definitely a yes and no type of field, right? And we need the evidence there, but so much neurological disease has a massive amount of gray in between. So for me personally, it was just being open to the idea that cannabis might work for my patients. I had one specific patient that kind of really was the straw that broke the camel's back for me when I was in residency, but it forced me clinically into a position where I had to change my perspective, right? So in such that, there were all these patients who were drug resistant, and a lot of them were coming to me wanting cannabis. It's not like they're coming to me wanting some drug that they would have to get a prescription for. They could just go out on the street and get it if they wanted. They could just go to a store and buy it and give it to their children, or they could buy it for themselves. So it presented this really unique situation that did force my hand to shift my perspective. And I kind of talked about this a little bit. It's like in physics. I don't know, some physics nerds out there. Like, the Newtonian physics is amazing. Newtonian physics can, we can launch satellites into space and make them orbit the Earth. We can land rockets on the moon. But when you get down to the nitty gritty of physics and you get really, 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 really small, you've got to go into the quantum world. You've got to shift your entire perspective. So it's almost like the same thing. It forced me into shifting my perspective away from relying on randomized control trials and guidelines and evidence to one in which I had to change and take on a harm reduction point of view. And be like, if I'm not the one who's going to care for these patients as a neurologist with epilepsy experience, they're just going to go get it elsewhere. They're going to go somewhere else. And if they're going to go somewhere else, they're going to be taken care of by somebody who doesn't have those expertise to the same degree. So it really did force me to look at medicine totally differently, and it shifted everything. It shifted my entire way that I practice medicine today, and that's my approach. My approach is very much a harm reductionist. When that approach calls, or I'll flip into my classical kind of neurology training type practice when the evidence is there.
Thank you for sharing that. And something that all of you mentioned were also, we have CBD, we have THC, and there wasn't much talk about full spectrum, right? And that's something that we hear on the other side as patients looking at it. So in your practice, Dr. Clark, do you have patients that are coming to you asking for full spectrum products, and how do you approach that when you're prescribing to patients?
Why did you give me that one? So the last fight I had in a boardroom was some company that is, talking to me about the 365 constituents that need to be in the product, that if we don't have them, the patient's not going to have the same effect. And I said, show me the data. There's no data. Receptors see, you saw Evan's pictures, they will see certain amounts of THC, CBD, potentially some of the other drugs. Show me any data where we need to have specific amounts of phytocannabinoids to have an effect at a receptor. I haven't seen it yet. Not saying there isn't something to the entourage effect, and the plant is natural and you must use the plant because that's where we're going to have the effect. But it's a bit of a story, just like we've been talking about for the past decade, and I don't know that the science supports the story yet, and so that's my take.
That's great, and it looks like Dr. Bell wants to add on that.
Well, I'm really just going to reiterate what Hans said, and that is that minor cannabinoids and terpenes just aren't ready for prime time. We just don't know enough about them. I mean, maybe that day will come, but right now we're just scratching the surface on the two major cannabinoids. Let's do that first. If we can sort that one out, let's talk about whole spectrum later.
And let me just jump in to say that I was part of an NIH panel talking about the role of minor phytocannabinoids, but they then have to be synthesized in amounts that become biologically plausible. And so when we have that data, I really think we can talk about it. And so we can talk about the two things that we know are active right now, and the other things, the data's still out.
Great, thank you. And that's exactly why I asked you the question. And Dr. Lewis, we've talked about the potential of minor cannabinoids, and when we have, your approach has been to have isolated ones so that it can use a dosing and titration method similar to other cannabinoids.
Yeah, so I think I agree. I agree with what Dr. Clark, Dr. Bell said. I think we really have to zero in on what CBD and THC are doing and their interactions. There's so many questions to answer there. There's obviously activity with just those predominant phytocannabinoids alone. I wouldn't throw the baby out with the bathwater, though. However, I think there is some data out there that does potentially support, at least an anecdote, that certain combinations of certain cannabinoids and minor cannabinoids can have an effect. And I think it's important to listen to that too, because cannabis kind of came to epilepsy by a lot of parents saying this worked for my kids, and people being ignored for a long time. So when I don't know how else to explain in my population when parents come to me and they say, hey, you switched me over to this other oil, and now he's having 10 seizures a week, when before he was at 1 a week. And we switch back, and it goes back to 1 a week. Or it comes back, I don't know how else to explain that, right? And so the way I look at it is, the problem with it is the computation that it will take in order to figure out the very specific number of cannabinoids that, at their whatever ratios, if that's even a thing, and how that's going to impact certain disease conditions and states. We're going to need quantum computing and AI to get a lot better. But one place I would direct everybody is Dedi Meir's research. So Israeli researcher in cancer, and this is phenomenal, if you want to go to the minor cannabinoid space. So he showed, through a series of doing this experiments, and he has a TED Talk, you can listen to him how he described this, that for a very specific leukemia that occurs from a Notch1 mutation, so very specific leukemic cells, you need precisely 3 cannabinoids. And if you add a fourth, so 3 cannabinoids will kill 90% of these cells. If you add a fourth, you go down to like 20% less. If you take away one of those 3 and just do 2 or any of them, you go down 20%. You go back up to the 3, 90% of the cells die. So, and he's worked out the entire mechanism with his lab, and exactly why that might be the case for this one specific mutation, right, of leukemia. I'm not an oncologist, but I'm sure there's many. So I think that's where we have to be mindful that this is a process, but that took him however many years. This has been his kind of life's work for the last 10 years plus. So this is how complex this can be.
Yeah, and I get the sense we have a lot of research to do over the next several years to be able to better understand a lot of these cannabinoids and their interactions, and we're, like you said, just scratching the surface. And one thing that we can consider too is how we have these different types of oils on these platforms as well. And we do have some physicians that say, well, there's a certain terpene in there that has effects on sleep that we would like to see on this platform. Or we have other physicians that are saying, well, we'd like to see a CBC-based product because we see that it has efficacy in autism. And for us, on this side, it's challenging to not listen to those requests. But we also have a fear of adding those products onto our platform, not knowing and not understanding the evidence that's backed behind them. So it's a little bit of a difficult balance to really come up with the products that we can have on our platform that are safe for the general audience as well. I'm going to open up the questions to the floor, as I do know that there's probably a lot of individuals that want to ask these great doctors some questions, so feel free to jump up there.
Okay, this is for Evan. Just curious, because I get a lot of adults coming to me with respect to epilepsy. So I've treated some of those rare diagnoses in pediatrics, but more so just advice for me on how to talk to adults when they're curious about CBD in epilepsy. Maybe they're resistant, maybe they're not. But maybe talk about both of those cases with your experience.
Both, you mean pediatric and adult? Or?
Just adults, like drug-resistant adults,
Yeah.
but also those who, I don't know if you have a similar experience where they come in and they're curious if this could replace their Dilantin or their...
Yeah, so it's a great question because it's a simple answer. First principles of epilepsy care always trumps everything else. So cannabis, CBD, THC, whatever ratio you want to put it, is just another anti-seizure medication to me at this point in time. It goes in my toolbox with my toolkit of all my anti-seizure medications, plus my other modalities that I can deploy at any time. Based on my training and my clinical judgment, I will deploy one of those tools at that time. So if they come in and ask me, that's exactly how I'll respond. It would be no different if somebody walked to the door and asked me about, I mentioned carbamazepine or valproic acid or one of the other drugs. I think it's the same thing, and I think that's really, really important to do. I think we have a duty to normalize this and normalize it within kind of the panoply of all the medications that we have. It's just another anti-seizure medication at this point in time. So that's a good question. So Dr. Pearson asked, when am I inclined to use it? So I think the implication there is first line, second line, or drug resistant. So drug resistance, I've already made the case, I think. I think maybe even for second line, I've maybe made the case. But again, this comes down to the first principles of epilepsy care. So if a patient walks in who has absence epilepsy, which has, there's a medication, ethosuximide, which cures this epilepsy 90% of the time. Right? I'm certainly not going to recommend cannabis at that time. So those apply. Okay, but then if the patient comes in, adult or child, and ask, and I get a lot of this. I get a lot of these referrals. First diagnosis, presentation of seizures, refuses conventional anti-seizure medications and wants cannabis. Okay, so here's where the model breaks down. If I'm going to be my traditional educated neurologist, where I was taught in medical school, I got a total line on every single guideline and evidence, and I wore that hat, what's going to happen? Right? They're going to doctor shop, and they'll eventually get it, and it might be not under an epilepsy specialist. So in the end, I have to alter my perspective. So that's a harm reduction approach. So I have a lot of patients like this, and again, that develops a bond with the patient. Now they trust you. 95% of the time that this has happened, the patient elects to go on the conventional anti-seizure medication with me, and then we might try cannabis second. And that 95% of the time that happens. And I think they just wanted to be heard. Like in the end, that's really what the real world experience is. They just want someone to hear their concerns, have a normal conversation with them that's educated, and then they trust you. Yeah. Welcome.
Hi, thank you all for your leadership. And Dr. Lewis, I mean, hearing a neurologist talk about harm reduction is really, it's really great to hear. I wanted to just sort of go on that theme a little bit, and maybe all three of you or someone has a specific comment. But we started to actually see an uptick lately in referrals that mention harm reduction from doctors out in the community and in the field that are referring into cannabis clinic. And I think we haven't done enough really, post-legalization and pre, to talk about different, the role of medical cannabis clinicians in harm reduction. We see a lot of smoked cannabis among people with chronic pain or even patients with epilepsy, right? And I wonder if you can talk about some techniques or success metrics to encourage patients to decrease their smoking habits and other interventions that could be suggested.
A lot of patients are looking for harm reduction. They come and you do a short interview and you find out that they're smoking a lot of cannabis on a daily basis. And a lot of times they recognize themselves and are starting to get increased pressure internally as well as from their family regarding the harms of smoking and inhalation. And I think my greatest success has been to recognizing that a lot of this is internally driven and to lever that. And move them into a phased approach where they can smoke less and use more orals. But frankly, in my big thing, and you may have got it from my talk, is the biggest thing that comes to my mind with harm reduction is opioid reduction. And I think that we are at a stage where we've got sufficient evidence to start applying that much more commonly in our patients who are using high doses of opioids for extended periods of time and are often themselves or their families looking to reduce their dosing.
Yeah, so I'll just follow up on what Alan's saying in terms of, and what you said, Aaron, in terms of Hearing a neurologist talk about harm reduction is astounding. Good stuff, man. So it is from our space in the pain world. It's what we do. It's what we've been talking about in terms of the opioid crisis for quite some time. But we had some observational data. I think it was Canvas RX. I can't remember. I think they were bought by Aurora or something like that. But we looked at about 1,000 patients that came through the clinics in Ontario. This would go back about 6 years, and it was stark to see that the folks that danced in the authorized cannabis space. At the start of that project, at baseline, 80% of folks were smoking. By the end of it, it was about a 50-50. So you will obviously see patients that will gravitate off of inhalational products onto oil products the longer they stay with a physician and they gain trust, et cetera, and you dance in this space. So again, it takes time. You have to do a lot of counseling, and a lot of docs, as Alan said, will get frustrated if they have to do that counseling, and then a bottle comes to a patient's house and they have no idea what was said in their interaction. So some of those things have to change.
I think also, we've been talking a lot about oils, but I mean, I've moved very much away from oils. I've moved very much away from primary care, but that's another story, towards soft gels or capsules, which are a whole lot easier for patients to use and titrate, and much easier. And, particularly in geriatric patients, they can't deal with those oils. Yeah. It's improving now, though.
And one thing that I just wanted to add is that that's something that our pharmacists spend a lot of time, is that education with those patients to help come off those high THC inhalation products, especially with our veterans who are sent to our platform with no knowledge, and that's the first thing that they turn to is vapes or high THC products. And we've now, over the last 6 months, had a lot of these consults, and we're starting to see slow changes in habits. It does take a long time, but that's something that we're really excited about. And that's similar to our insurance formulary, where there are no high THC products allowed. So you can see the big differences in the populations and what they're using there versus if they were to go to the general markets or not have a controlled environment. And that's something that those providers that we do work, so insurance groups that we have preferred provider relationships, such as WSIB and WorkSafe BC, we're able to format those formularies, whereas the ones that we're doing direct billing and aren't really willing to have those discussions about preferred formularies, we start to see patients trying to get products that are higher in THC. And that's something that I want those insurance providers to also be open to, is discussing what is the best harm reduction approach for patients that are seeking medical cannabis and will get it anyway. So in lieu of time, thank you all for joining us for a great panel, great presentations, and time for break. Thank you.